what you doing? Well, I'm supposed to be up here studying, but, you know, I'm reading a magazine. I'm not studying for it. We went to the hardest nursing school. I mean, my word, how much more can one person know, okay? What about you? Have you been studying for it? No?
What you doing?
Hold on a minute. My little sister's in here.
What are you doing?
I'm studying for NCLEX, something you know nothing about.
No,
and I want you to go on because I've got a lot to go over.
That is Tom Cruise.
Go on.
No,
I'm telling you to go
you're
on.
on the phone.
Hold on a minute. Get out of here.
You're not supposed to be on the phone.
I'm telling you to get out of here, little girl.
What is going on in here? I'm trying to watch
Let me
TV
call
and
you
watch
back.
the
Let me call you back.
football
My
game.
little
Mama,
sister's
what is
here.
going on? Mama, you need to get a job.
Go to your room now. You
I can't get a job till I pass.
What's wrong? What's
Daddy,
wrong?
I'm
It's
trying to
okay.
study for
What
an
has she
exam,
done now?
and she will not let me concentrate.
I
I'm
know
so
you
stressed out.
are a great nursing student. You done passed school. You're gonna be fine on that test. You've already taken Hearst Review.
I know, but I'm trying to study, and I've got the cramps, and she keeps coming in here.
You're gonna be just fine.
I
Okay,
can't
you're
take
gonna be
it
fine.
anymore,
You've been
Daddy.
a great student. You've been studying this whole time. You're
Well,
gonna be
make her leave me
fine.
alone.
I am. You are grounded. Okay. I'm gonna go get you some My Doll, and I'm gonna get you a
Please, I'm
Coke.
hurting
Okay.
so
I'll be
bad.
right back.
Okay. They're gone now. Yeah. I guess I'm going to have to study. I don't want to, but I might. But look, if you study a little while and want to go out, call me later, okay? All right, we'll go ride. Bye. Let's talk about psychiatric nursing now. Now, y'all, in this section, you can be happy that we are not going to cover every single psychiatric illness in the whole wide world. We are going to learn the basics of psychiatric nursing. Okay, because if you even get a question on it, they could make up a name of a disease that you've never even thought of before. But we're going to show you with these basic principles how to answer psych questions, okay? Now, a very important part of psychiatric nursing is therapeutic communication, right? Now, therapeutic communication is in every single area of nursing, okay? Whether it's med-surg, OB, peds, or psych. If you want to really improve yourself as a nurse, all that corny stuff that we learned about therapeutic communication, start implementing it. It'll make all the difference in the world, because you probably have seen people that talk too much when they're talking to patients, and that gets you in trouble, okay? There's a reason that there is an art to therapeutic communication. So implement it when you get out there and start working. Let's look at depression now. It's a loss of interest in life's activities. They have a negative view of the world, and they have something called anhedonia, which is loss of pleasure, and usually pleasurable things. In other words, things that you used to enjoy, you just don't enjoy anymore, okay? Usually related to loss. Now, y'all, does loss always have to mean death? No, it may mean loss of a job, loss of a body part, like mastectomy patients. It may mean loss of self-esteem, like with rape patients, okay? So loss doesn't always have to mean death. Now, what does this patient look like? Do they have a well-kept appearance? No. Y'all, they don't have the energy to fix themselves up. Weight gain in mild depression, weight loss in severe depression. Crying spells are noted with mild to moderate depression, and no more tears with severe depression. Patients may be irritable due to decreased serotonin. You know, that's a mood regulator, isn't it? Okay? Now, do depressed people have energy? No, they don't have energy. And is there a chance they might need help with their self-care? Yes. Initially, especially in the acute stages of depression, they might have to have help with their bath and putting on their clothes and that sort of thing, simply because they do not have the energy. We want to help experience accomplishment, because if we can help them experience accomplishment, we know that their self-esteem is going to go up. That's a biggie. You want their self-esteem to go up. Now, be careful with compliments. For some reason, they can make the patient feel worse, because it's like you're pointing out things about them, all right? So you have to be careful with compliments. Prevent isolation. As you know, depressed people like to be what? Alone. Interacting with others actually makes the patient feel better, even if they don't want to do it, okay? And they may tell you, okay, I'll come to the day room at 5 o'clock for the group meeting. Will they show up? No, you've got to go and get them. In fact, one of my favorite strategies for answering psychiatric questions is to be active. Get up, get away from the nurse's station, and seek out the patient. They love that answer on NCLEX. Seek out the patient because they are not going to seek you out. That's why they're in the hospital. If severely depressed, sitting with the patient and making no demands may be the best thing that you could do. Now, can these people make simple decisions? No, they have a hard time making any decision. And I've also found that once they finally make a decision, then they worry about it, right? They worry about the decision that they've made. Now, we must assess the suicide risk. Now, y'all, not everybody who is depressed is at risk for suicide. But remember, we must assume the worst. As the depression lifts, what happens to the suicide risk? It goes up because now they have the energy, right? Now they have the energy to go ahead and complete the task. A sudden change in mood toward the better may indicate that the patient has made the decision to kill himself. Elderly patients are particularly at risk for suicide, and elderly men tend to be very successful by using lethal methods. Now, can depressed people have delusions and hallucinations? Yes, but not everybody who's depressed has delusions and hallucinations, but you can. And are their thoughts slowed? Yes. Now, why is that important? Because now that you know that their thoughts are slowed, it's going to change the way you communicate with them. You need to slow down. You need to slow down when you're talking to them. And this is a perfect time to use the therapeutic communication technique of silence, because you're giving them time to process information. Silence, because you're giving them time to process information. All right, moving on. They can't concentrate. Sleep disturbances are common. In mild depression, they may have hypersomnia, where they want to sleep all the time. And in moderate to severe depression, they may have insomnia, can't sleep. Generally, depressed patients have difficulty falling asleep, staying asleep, or have early morning awakenings. So see, the sleep troubles can manifest themselves in lots of different ways. Now, just the very opposite of depression is being manic, right? Like with bipolar disorder. All right, how many of you have taken care of somebody that was manic before? A few of you have. And you were tired when you got home from clinical that day, weren't you? From chasing that person up and down the hall. Okay, manic, continuous high. Their emotions are very labile and they have a flight of ideas. Remember trying to have a conversation with a manic person? It was very difficult, wasn't it? Now, delusions. A delusion is just a false idea, like a delusion of grandeur. A delusion of grandeur, like you think you're Jesus, right? Yes, you think you're Jesus. Delusion of persecution. You feel persecuted all the time. Somebody's out to get you. Now, do you argue about the belief? You're not supposed to. You don't sit around and say, look, you are not Jesus. Look at yourself in the mirror. Come here. Look. You don't have the sandals or anything. You can't talk people out of it. They believe they're Jesus. Do you talk a lot about the delusion? You're not supposed to. But wasn't it fun to talk to your psychiatric person at clinical? Yes, it made the day go much better, didn't it? Yeah. And you ask questions like, what's it like to be Jesus? Right? You weren't supposed to. And all the way home you said to your friend, let me tell you what my man said. You're not going to believe this. Listen to this. This is so funny. You're not supposed to do that. You let the patient know that you accept that he or she needs the belief, but you do not believe it. Y'all, they need the belief because that helps with their security and their self-esteem. Yeah, I guess if you felt like you were Jesus, you'd feel pretty secure, right? Yes. Now, what we do is we look for the underlying need in the delusion. For example, delusions of persecution, the need is to feel safe. Delusions of grandeur, the need is to feel good about self or self-esteem needs. Okay? Now, constant motor activity, which can lead to exhaustion. At some point, that motor activity, that running up and down the hall, getting in everybody's room, might have to be interrupted, right? You don't just let people run themselves to death up and down the hall until they have a heart attack one day. Now, do you? No. Inappropriate dress. Well, first of all, they dress wild. It's inappropriate. They may have on, inappropriate for the situation. You know, they may have on a huge cowboy hat and 20 necklaces and lots of makeup and boots and a thong on at craft therapy, okay? You see how inappropriate? Another thing is they like to dress seductively. That's true for men and women. That's an attention-getting mechanism. But they don't understand what the problem is when they show up in their thong for craft therapy. What's the problem? Okay? Everybody, they think you've got the problem. They don't understand what the problem is. They can't stop to eat. They're too busy. And we're going to see that that's why we have to give them finger foods, right? Things that they can hold in their hand and run up and down the hall and eat. Calories are very important here. They're losing weight. Altered sleep patterns. Well, do they ever sleep? No. When they're in the acute stages of mania, they are up all night long, okay? And they're always at the nurse's station with you, here at the nurse's station. And if they're not here, they'll be right back, okay? They'll be right back because this is home base for the manic patient. You see, they really like to hang out with y'all. They like to hang out with the nurses because they feel like they're one of y'all, helping y'all take care of those people, right? Yes, that's the way manic people think. Altered sleep patterns, spending sprees. They love to spend money that they do not have. They'll max out credit cards and that sort of thing. Makes them feel powerful. Poor judgment, no inhibitions. This goes back, think about the clothes thing. Not wearing, dressing too seductively. They have no inhibitions. They may be hypersexual and may exploit other patients as well. Now also, they like to manipulate. Now, when I say manipulation, I mean manipulation with the things that they say, okay? And when the manipulation fails, in other words, you figure it out and stop it, then they get mad at you. They turn on you. Manipulation makes them feel secure and powerful, and you have to set limits, and the staff must be consistent. Okay. See, they'll sit there and give you all kind of compliments. It's 11 to 7 maybe, and where's Manic at 11 to 7? With you at the nurse's station. He's standing there talking to you at the nurse's station. All right? And you're trying to chart. And he says stuff like, you know what? You're the best looking nurse here. I know the administrator. I can get you a raise. You're going to be the head nurse, girl, before I finish with this place. And you may be sitting there thinking, well, maybe he does know the administrator, and you're going along with it, okay? No, you can't go along with it because they're manipulating you through their conversation. You see, you've got to interrupt it and send them to their room. Don't listen to that stuff, okay? And they have a decreased attention span, and yes, they can hallucinate. Now, treatment, decrease the stimuli. The TV's got to be off, the radio. I mean, if there's a lot of activity in the room and you've got somebody that's real, getting more manic by the minute, you've got to calm down the atmosphere. You got to get them out of the environment that's making them feel wild and manic. Limit group activities. Do manic people do well in groups? No, they ruin it for everybody. That's why we don't let them go to craft therapy very often, because here's poor depressed person over here, been working on his little popsicle stick house for 2 weeks, right? Got one wall up. And then Manic comes in and says, look, I got an architectural engineering degree from Mississippi State University. Let me show you how to do it, right? Right. They try to take over. They ruin everything. Make other people feel bad about their progress. Feel most secure in one-on-one relationships, and you got to remove hazards. Y'all, a manic person can hurt themselves with a cotton ball. You can give them a cotton ball to play with, and I promise you they will come back and they will come to the nurse's station with it in their eye, wanting you to extract it, okay? But other things you got to think of are like cigarettes. You've got to watch them with the smoking. You only give them one. Don't give them a pack of cigarettes. They'll have 4 or 5 lit at one time, okay? You give them 1 or 2 and monitor their smoking. You stay with the patient as the anxiety increases, because if you stay with them, you can keep them calmed down. That's the name of the game. Stay with them. Structured schedule. Well, a structured schedule makes everybody feel more what? Secure. That's a security thing. We need to provide activity to replace purposeless activity. But do you have to be careful with the activities that you give them? Yeah, because they can hurt people, right? I mean, even if you give them a broom or a mop, can they knock somebody out with the mop? Right. Okay, so you got to be careful. Writing activities provide energy outlet without too much stimulation. You see, too much stimulation being a key there. Brief, frequent contact with the staff is very important. Too much intense conversation is going to stimulate the patient. There's the finger foods again. Keep snacks available. Weigh daily. Remember, y'all, they're losing weight. Calories are very important here. Walk with patient during meals. They'll eat better that way. If you walk with them, spend some time with them. You don't argue or try to reason with them. What's that going to do to their anxiety level? Increase it. That's not good. We're not in the business of stimulating this patient. They'll try to charm you. And I mean compliment you is what I'm talking about. Compliments. All right, that's a form of manipulation. They blame everybody for everything. They don't know what the problem is. They don't have a problem. It's you with the problem. Make sure their dignity is maintained. For instance, when they take off their clothes and run down the hall to the day room, you've got to go and get them covered up and get them back dressed again, okay? Patient may do things or say things that they wouldn't normally do. So you got to remember that about people. They don't mean to do what they're doing sometime. I mean, you'll hear about the most innocent, sweetest little lady who stood naked on the top of the piano in the day room, okay? Well, she's going to be mortified when she finds out about that later. Okay. And I've listed for you some drugs there. And at the end of the packet, I've got a little synopsis of psychiatric drugs for you, okay? Remember, drugs are memorization things. Schizophrenia. The focus is inward. They create their own world. You know, they love to go inside of themselves. They've learned how to retreat from the world, and they go inside of themselves. Inappropriate affect or flat affect or blunted affect. An example may be, maybe they're talking about their mother who died a tragic death, and what are they doing while they're talking about it? Laughing about it and smiling. That's an inappropriate affect. Disorganized thoughts. We call that also loose associations. Interrupted connections in thought and confused thinking. Rapid thoughts. They jump from idea to idea. They have something called echolalia, and that's when they hear a word and they repeat. They repeat that word. What's a neologism? Making up new words. Making up new words. You always seek clarification. You say, I don't understand. Don't you ever act like you understand that word. And don't you start using the word yourself. Because what is that going to do? Reinforce it. You don't want to do that. Do these words mean anything? No. They're concrete thinkers. Well, now, that's important for you to understand. They're very concrete, and they interpret what you say so concretely. For instance, if you tell them to, now clean your plate, what do they think they're supposed to do? Wash it. So you've got to be careful with the way you word things to a schizophrenic. And of course, it all depends on the degree of schizophrenia that they have. Just like anything else, you can have a little bitty case of it or a full-blown case of it. Word salad. That's just a jumble of words. Jumbles of words. Y'all, all these disorganized thoughts and rapid thoughts and echolalia and neologisms and word salads, do you think that alteration in communication is a top nursing diagnosis? Absolutely. Alteration in communication is a top nursing diagnosis here. They can have delusions. And they can have hallucinations. Auditory are the most common, all right, and visual will be the next most common. Childlike mannerisms, too. Sometimes they can regress so much that they'll go all the way back into the fetal position, okay? Childlike mannerisms. Religiosity. Really talk about the Bible all the time, or they carry their Bible with them everywhere and preach to everybody all the time. Treatment. You've got to decrease the stimuli. And here's a biggie. Observe frequently without looking suspicious. Y'all, how many of y'all were scared when you did your clinical at the state hospital? I was. And I used to take students with me to the state hospital, just scared to death, and I'd always say, now stay around me at all times, okay? And then I've seen the way students will check on their little psych patient. They peek through the crack in the door at them because they're scared to go in the room. Now, y'all, if a psych patient sees this, especially a schizophrenic, what are they going to think? They're going to see a big, huge eyeball, and it scares them to death, doesn't it? You don't peek at people. That makes you paranoid, whether you've got schizophrenia or not. You knock on the door and go in and see what's going on, then run away, run out, okay? All right. Orient frequently. Important to remember that the patient may know person, place, and time and still have delusions and hallucinations. Okay. Keep conversations reality-based. Keep them in the real world. And make sure personal needs are met. And then they have medications that can be used too, which that's in your little packet in the back. And please understand, as I do this lecture, I'm trying to make it fun because it's the end of the day. I'm not making fun of psychiatric illnesses in any way because I've had most of them. All right? Okay. Now, suicide. Do they have a plan? And what is the plan? How lethal is the plan? Guns, car crashes, hanging, and carbon monoxide are very lethal plans. We also want to know, do they have access to the plan? And had they ever attempted? If any of that stuff is true, the risk just went up. All right. We need to watch for things like isolating themselves, writing a will, collecting harmful objects, and giving away their belongings. No matter how trivial the belonging is, if they're giving their stuff away, that's a sign. Elderly men are particularly at risk and are successful in attempts. Number one thing to remember is to provide a safe environment. Safe-proof the room, which is almost impossible to do, right? Because if people really want to hurt themselves, they can find something to hurt themselves with. And with some people, you can contract to postpone. You know, that's where you make a contract with them that for 24 hours they will not bring any harm to themselves or anybody else, okay? And you'll have people that will stick to the contract. And you're hoping in that period of time that they will develop some coping mechanisms or see things differently. I mean, hadn't you ever been mad when you went to sleep and you got up the next day and felt different about a situation? Yeah, it's amazing what a little time can do for you, okay? So contracted to postpone. Just don't forget to renew the contract, okay? Okay. Direct closed-ended statements are appropriate. Hallelujah. I can't believe it. Finally, I can use a direct closed-ended statement because in nursing school, what do they always tell you to do? Open-ended, right? Open-ended to generate more conversation and gather more data while keeping the patient focused. Now I can get straight to the point. Now, what's the NCLEX perspective on this? If you are talking with someone and they even give you a little tiny smidget of a hint that they may even be thinking about bringing harm to themselves, can you confront it directly and say, are you thinking of killing yourself? Can you say that? Yes, you can be that abrupt. It is okay to be that direct here. In fact, the NCLEX people are scared you aren't going to be that direct. Well, if you aren't that direct, could you brush off a big problem? Yeah, we don't want to do that. You got to get direct and to the point. It is okay here. They want you to. Rechannel anger through exercise. This is true for everybody in the whole wide world. Anytime you have tension or an anxiety, we need to exert ourselves. Exert ourselves. So I have two patients in the day room, and they're fighting over the TV. One wants to watch Oprah and the other one wants to watch Montel. And you can hear their voices getting more tense, and you walk in the room and you say, wait a minute, okay, I got something for us to do. Shall we go on a long walk around the lake, or shall we carry them to a punching bag? Ask your friend what you would pick on NCLEX. Come on, pick an answer. What you think? Okay, I hear punch a bag, and I heard one or two of you say long walk. Most people pick the long walk because doesn't that sound therapeutic? Yes, let's go with my 2 psychiatric patients on a long walk. 7 miles on a long walk. And the whole time while I'm gone, what am I planning on doing to you? I'm thinking about how I'm going to whoop you when I get back, right? That's right. So what you want to do is you've got to pick the activity that is most exerting. You pick the punching bag to get out all that negative energy. But see, people fight that answer. They're like, I've never seen a punching bag at a hospital. Does it matter if you've seen it? No. As long as it doesn't bring harm to the patient, then you pick it. That's the most exerting activity because the concept is to get them to exert themselves. Now, somebody in their brain right now is thinking, but won't that promote violence? Well, I'm just glad they're beating the punching bag instead of me, right? Right. Stay calm because anxiety is contagious. You know that. Have you ever felt good about a test at school until you got to school hanging out in the hall with your friends? All right, everybody's talking about it. You're like, I thought I knew something, right? And then you try to run and try to look up something. That's just anxiety. Now, we're talking about suicide here. If there is a suicide attempt on the unit, you're in a psychiatric unit, you don't want the whole unit to find out about it or you're going to have total chaos, aren't you? Right. Well, all the psych patients already know something's wrong down there in room 210 because a lot of people are running in and out and the ambulances come. They know something's going on and you've already told them to all go to their rooms. Or they're all in their room, but all their heads are poking out the door, right? Right. Y'all, if the whole unit finds out about it, we're going to have total chaos. Depressed is going to be over here more depressed than they've ever been. Schizophrenic's under this table here, right? Making up words you ain't ever heard of before. And what's Manic doing? He's triaging everybody for you. He's charting for you. He's giving your medicines and taking vital signs, and you're glad he's doing it, okay? Because you've never had so much paperwork to do in your life. You don't want the whole unit to find out about it. Restraints now may have to be used with suicide people. Now remember, y'all, on NCLEX, suicide, restraints, any kind of restraint is a last resort. We hate restraints. NCLEX people hate nurses that tie down people. Well, if you do use them, though, check every 15 minutes, and don't forget hydration, nutrition, and elimination. You see, especially if somebody has been violent and 4-point leather restraints are used, if that patient just beats you up, people have a tendency to restrain them, and they're like, I'm not going back in there tonight. He just knocked the heck out of me, all right? That's not nice. You still have to remember to let them have something to eat and drink and help them go to the bathroom, okay? Observation at 15, 30-minute intervals or one-on-one if the patient cannot contract for safety. If you don't feel comfortable even leaving them for 5 minutes, you stay with them. And you may say in your brain, well, I've got other people to tend to. No, you don't. The only person you have to tend to on NCLEX is who? The one on the screen. That's it. You cannot say, I have other people. The only one they're interested in is that one on the screen. Okay, now I'm paranoid. Always suspicious, but have no reason to be. You know, there are times in life when you're supposed to be suspicious. You've got a mechanism of paranoia, intuition, we call it, being built in. I mean, haven't you been in a situation before where you just felt uncomfortable about it? Okay, that's intuition. That's something that's been put inside you for a reason. These people are always suspicious but have no reason to be. Why? Because they're responding in a way that is consistent with their paranoid beliefs. They just are paranoid about everything. Remember, you can't explain away delusions or false beliefs that they have. Guarded in relationships simply because they do not trust. Paranoid people do not trust. They've got a big problem with trust. They have pathologic jealousy. Well, at some point in time, everybody in the world has been a little jealous of something. That's why they call this pathologic jealousy. It consumes their thoughts and consumes their mind. That's all they can think about. Hypersensitive. We've all known somebody before that you just can't say anything to, right? I mean, have you ever said something to somebody like, your hair looks different today? And they're like, what's wrong with my hair, girl? Okay? You have to be real careful with some people. That's what I mean by being hypersensitive. They can't relax, no humor, they're unemotional, they crave recognition. Life is unfair. You've had it easy. You've had an easy life. You hadn't had the troubles that I've had. Life has been unfair for me. You've got it made. Everybody else has the problem. They don't have a problem. And when they get mad, they react with rage. They do not have a normal anger response. Treatment. Be reliable. Now, you put you a big old star by that. If you say you will do something, you must do it. You think about it. Paranoid people are expecting you to not do what you said you were going to do, right? What is the number one thing we're trying to build with this person? Trust. Brief visits. Be careful with touch. You know, a paranoid person cannot handle the touchy-patty, huggy kind of nurse. There are people that you can touch and hug and that sort of thing, and then there's people that you cannot. I mean, have you ever just met somebody before and they hugged you real big and you felt like, oh, this is too much, okay? You just felt weird about it? That's what we're talking about here. All right? Respect their personal space. Well, everybody's got personal space. But when you're paranoid, it just got even bigger. You stay back a little bit, okay? Avoid whispering because they always think you're whispering about them. Don't mix their medicines. They know their medicines and they know the number on the side of the pill too, okay? So you've got to be sure and just be upfront about their medicines. This is this one, this is this one, and this is this one. You're not trying to hide anything. Can't handle the over-friendly. That's the touchy-patty nurse. Be very matter-of-fact. I'm talking about in your tone. When you're talking to somebody, you're very matter-of-fact, not a lot of inflection in your voice, because if you have too much inflection, they try to start reading into what you just said, putting too much into what you just said. Always identify the medicines. Eating, they'll eat sealed foods or food from home, okay? Because, y'all, they think everybody's trying to poison them. With time, though, we hope that they'll eat what everybody else is eating. And they need consistent nurses because what are we trying to build? Trust. I really have said that a lot. Paranoid people cannot handle competitive activities at all. They can't handle it. They'll act like a first grader playing ping pong and throw the paddle down and run out of the room and say you cheated. It makes them feel so humiliated when they don't do well in a competitive activity. And be very honest. Now, that's with everybody. But you have to really be careful with paranoid people. Because if they're standing at the door of the unit, which they always are when you did your psych, they're always at the door looking out the window, right? And you're wondering, how am I going to get out the door with these 10 people here, right? Okay. Well, they're looking out the window down at the nurse's station, and they see their wife come up and sign some papers. If you don't tell them wife came to sign the insurance papers, well, they read all kind of stuff into that. Yes, you've got to be careful. Anxiety. Everybody's had this. It's a universal emotion, and we've all felt anxious. It becomes a disorder when it interferes with normal day-to-day functioning. General comments about anxiety. It increases performance at mild levels, decreases performance at high levels. Patients may not need the nurse's presence in mild anxiety, but however, the nurse should stay with highly anxious patients. The patient who is highly anxious needs step-by-step instructions because can they make decisions? No, they cannot. Generalized anxiety disorder. Chronic anxiety. Person lives with it daily. And they're fatigued due to constant anxiety and muscle tension. They're always uncomfortable, and they seek help usually because their life is the quality of life is so poor. Treatment includes short-term use of anxiolytics, relaxation techniques, deep breathing, imagery, deep muscle relaxation, journaling over time to gain insight into anxiety, and also it helps them identify peaks and valleys and then triggers to their anxiety. Now, post-traumatic stress disorder. Results from exposure to life-threatening event, like a severe trauma, natural disaster, war. All right, relive the experience, nightmares, flashbacks. That's one of the things that they do. All right, emotional numbing. They get to where they don't have emotion about many things at all. They have difficulty with relationships because they are so numb, right? That's a protective mechanism to make yourself numb. Isolate themselves. Treatment, support groups. Talk about the experience, but don't push, and medications can be helpful. Obsessive compulsive disorder. An obsession is a recurrent thought. A compulsion is a recurrent act. They can't stop. Y'all, they wish they could stop because is this interfering with their day-to-day activities? Yes, they wish they could stop. It comes from an unconscious conflict or anxiety. Something inside, they don't know what the anxiety is or what's causing it, but something is making them real anxious and for some reason doing things like checking the lock on the door 12 times before I leave or washing my hands 13 times in a row a certain way relieves my anxiety. That's the purpose of this behavior, is to relieve anxiety. That's very important. Y'all, they need a structured schedule. Now, in this schedule, do we give them time for their ritual? Yes, you do. Now, anxiety level goes up if he can't perform the ritual. Okay, what if I'm an old Army med-surg nurse for 35 years and I get pulled to the psych unit today and you give me shoe tire? Well, I'm used to med-surgy stuff. I ain't got time for this. And the whole time you're giving me report all therapeutically, what am I thinking? I'm going to fix this today while I'm here. And so you go in the room and there's shoe tire, tying his shoes. You shut the door behind you and you look at him and you say, you ain't tying your shoes today, baby. What's he going to do? Have a panic attack, right? What if you told him you were going to put Velcro shoes on him? What would happen? Panic attack. You give them time for their ritual because that's the only way they have to decrease their anxiety. But what do you start doing with the amount of time? Decreasing it. You start decreasing the amount of time that you give them. You should never take away the ritual without replacing it with another coping mechanism, such as anxiety reduction techniques. Do not verbalize disapproval. I mean, they already feel bad enough about it as it is, right? And treatment includes time-delayed techniques, relaxation techniques, medications such as your SSRI or your tricyclic antidepressants. Now, dissociative disorder. The patient uses dissociation as a coping mechanism to protect self from severe physical or psychological trauma. May see with clients who have a history of physical or sexual abuse, not commonly occurring or seen. Client nor others may be aware of the problem, except the client may have periods of time or events that he cannot remember. It's like they slip off into another world. Dissociative identity disorder, you've heard of this, multiple personalities, is an extreme example of dissociative disorder. Treatment, patient must process the trauma over time, and medications may be used to treat the coexisting depression or anxiety. You see how we're studying real in general here, and it seems like the same principles are applicable to lots of different psychiatric illnesses. All right, now alcoholism. Alcohol is a depressant, and if you drink it long enough and try to stop, you will go through the stages of withdrawal, okay? And here are the stages here. Stage 1, mild tremors, nervous, nausea. Stage 2, increased tremors. They're getting a little hyperactive now. nightmares, disorientation, hallucinations, increased pulse, increased blood pressure. Stage 3, most severe. This is where you're scared for the patient. Most dangerous, severe hallucination. Visual and kinesthetic are most common. They feel like things are crawling on them. And grand mal seizures. That's what makes it so dangerous, the grand mal seizure. Stage 2 and 3 are the DTs. Alcohol withdrawals, delirium. Keep the light on. Y'all, these people are very scared during this time. You don't want them in the dark, and besides, they're probably not going to be in the bed, so you want them to be able to see their environment real well. Stage 1 and 2, walk and talk to them. The more you walk and talk to them in stage 1 and 2, when they finally come out of it, the better off they're going to be. Now, when I say walk and talk, I mean you are going to orient somebody 1,000 times. And if you are not a patient person, you do not need to sit with somebody going through withdrawal, okay? Because you are going to say the same thing over and over and over again. Anxiolytics. Don't be afraid to give. Remember that the patient has a tolerance to alcohol and a cross tolerance to other CNS depressants. He can handle medications every 2 hours. DT should be prevented. You just don't let people suffer through it. The patient is very frightened during the episode. Detox protocol usually includes thiamine injections. We'll talk about that in a second. Multivitamins and maybe even magnesium. We'll talk more about all of that in a second. Now, chronic problems caused by the thiamine and niacin deficiencies. In other words, your B as in boy, B vitamin deficiencies. They haven't been eating properly. B vitamin deficiencies. So they develop things like Korsakoff syndrome, where they're disoriented to time and they confabulate. Your teacher told you that confabulation is just when they can't remember, they just make up something, right? To fill in the gaps. Make up something to fill in the gaps. Wernicke syndrome is when the emotions are very labile, they're moody, and they tire easily. Now, y'all, here's the deal. People don't know that they've got Korsakoffs and Wernicke's. It's the family that has to deal with this, right? So they can come off the alcohol and detox, but now they've got these chronic problems that the family has to deal with, so now we've got more family stress. Other signs and symptoms, peripheral neuritis. That is because of the B vitamin deficiencies. B vitamin deficiencies. Affects the nerves, in other words. Liver and pancreas problems. Alcohol kills your GI tract. Alcohol kills your GI tract, and we're going to talk more about that tomorrow. Impotency can occur. Alcohol kills nerves. Alcohol kills nerves, as well as the B vitamin deficits. Gastritis, that's just another GI tract thing. Now, magnesium and potassium. Tell the person sitting next to you why the alcoholic has so much trouble losing their magnesium and potassium. Come on, talk to each other. What does alcohol make you do? Diurese. And the two electrolytes that are lost with diuresis are? Yes, magnesium and potassium. Major defense mechanism, denial and rationalization. They deny they have a problem, and then if they do drink, they're telling you, well, it's okay to drink. It's good for my heart, right? Antabuse is a deterrent to drinking. Before antabuse, the patient has to sign a consent form and must stay away from any form of alcohol, including cough syrups, aftershaves, colognes. There's even some types of chemicals like varnish and that sort of thing. Anything that has alcohol in it can absorb through the skin and can make them have a bad reaction. 12-step program is very effective treatment, and the client must have a relapse prevention plan in place and must have support once detox is over. Family issues emerge once the alcoholic is sober. All of the dynamics change. We're talking about within the family, and so this causes stress. Now, with other substance abuse and addiction, the issues are the same. Intense craving, difficulty quitting, many attempts to quit, Fatal if left untreated. Again, they use denial and rationalization, and the patient's life is controlled by the drug. They wake up every day thinking about that drug. Now, anorexia. With anorexia, the patient has a distorted body image. They see a fat person when looking in the mirror, even when they weigh 75 pounds. Okay? So their actual perception, what they see, is distorted. They're preoccupied with food, but they won't eat. They like to plan meals for everybody else. Their periods stop because they're so malnourished. They have decreased sexual development. They can become so regressed and so malnourished that they'll even develop lanugo over the body like a newborn baby. The hair, the fine hair all over the face. Exercise, 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 and yes, they do lose weight. And yes, you can look at somebody and tell if they have anorexia because they're so skinny for their age. They use intellectualization as a defense mechanism. They're a high achiever, perfectionistic. Treatment. Increase weight gradually. Monitor their exercise routine. I mean, really, you may not even want them to exercise any, depending on how small they are. Y'all, we are in the business of keeping people alive, right? Yeah, so you're not going to let them exercise much. Teach healthy eating and healthy exercise, and allow patient input into choosing healthy food items for meals. Limit activity and decisions if weight is low enough to be life-threatening. The skinnier they are, the fewer decisions they're going to have in their treatment, because we're in the business of keeping people alive. Now, bulimia. They overeat and then make themselves vomit. They'll go out to a restaurant, eat what everybody eats, and then they'll excuse themselves to the bathroom to go and vomit then. So, if they're vomiting so much, what starts happening to their teeth? Yes, they rot. The enamel erodes. The enamel erodes. Therefore, who may be the very first person to pick up on this? The dentist may be the first person to notice it. They use laxatives, diuretics, anything to lose a pound. They don't care how they lose it, just want to lose a pound. Strict dieter. They fast, they exercise, and they binge. This is one thing that makes bulimia different. Their binges are alone in secret. They don't want anybody to know they're binging. They're out of control when they're binging. They may consume thousands of calories at one sitting. They may steal food from the grocery or from a garbage can. Any way to get food. Patient spends more and more time obtaining food, and the binge initially is very pleasurable. But when they get to the end of consuming these thousands of calories, they can have intense self-criticism then. Now, what's weird about the bulimic is they have a normal weight. Don't get me wrong. If their normal weight range is 120 to 140, they're going to weigh 120 at the lower end of it, you see. That's different than an anorexic because they're not going to be anywhere close to their normal weight range. With both anorexia and bulimia, they feel like they are in control as long as they can eat or not eat like they want to. I said as long as they can eat or not eat like they want to. Which is going to pose a problem at the eating disorder clinic. Because at the eating disorder clinic, if you're really wasting away, are they going to let you do what you want to do? No, they're going to give you a choice. You can either eat what we provide in the time frame in which we provide it, or we can tube feed you. Now, doesn't that sound mean? That sounds threatening. But what are we in the business of doing? Keeping them alive. Treatment. Sit with patient at meals and observe for 1 hour after to make sure they don't go in, throw up. Allow 30 minutes for meals. That's it. They have to eat within the time frame that you provide, because here's the deal, y'all. We're taking the focus off of the food. The food is not the problem. We're taking the focus off the food. Angry because you've taken their control away. Family problems, usually the cause. Family tends to deny conflict and problems, and self-esteem building is very important with these people. Personality disorders. Most commonly encountered is a borderline personality disorder. Patients are intensely emotional, manipulative, suicidal gestures, self-mutilation, may also be depressed or bulimic, and may abuse substances. They have a fear of abandonment, many negative relationships. The reason they have so many negative relationships is because of the next sentence. To this person, any relationship is better than no relationship. You see, they don't have real high standards for the person that they choose to be with. They'll just be with anything. So no wonder there's so much trouble. But see, they want to be with somebody because they're so scared of being alone. And they may be sexually promiscuous. Treatment: improve self-esteem. Treat any co-diagnosis that they may have, whether it's depression or their eating disorder. Relaxation techniques: enforce rules and limits. Put a star by that. Don't reinforce negative behaviors. Like if they're manipulating and that sort of thing, you don't want to reinforce any negative behavior. Treat self-mutilation and suicidal gestures in a matter-of-fact way. Now, we're taking it serious, don't get me wrong, but you're taking the focus off of that because, see, that's more like an attention-getting mechanism, okay? Now then, let's look at a phobia. With a phobia, does the object the person is scared of present danger? Not usually. I mean, I may have a fear of elevators, but as a rule, are elevators life-threatening? Not as a rule. Yeah, they can be. Okay? And they must have a trusting relationship. That's the key. I've got to make sure that you aren't going to make me face my fear before I'm ready. Okay? I've got to be ready to face my fear. Desensitization is the key, and that occurs over time. Now, what is desensitization? Gradual exposure to my fear. Gradual exposure. And you're letting me work through my anxiety in stages is what you're doing. You don't talk about the phobia a lot. Believe it or not, it's just like with those self-mutilation behaviors I was talking about earlier. You're taking the focus off of the phobia. Earlier, we were taking the focus off the self-mutilation behavior. You don't want to draw too much attention to it, you see. Follow-up is the key to successful treatment. It takes a while to desensitize somebody. Now, we don't talk about the phobia a lot. I'm going to emphasize something here. What I mean is you're not sitting around talking to them about, oh, what's it like to be scared of an elevator and all that kind of stuff. Something inside is the cause of this problem. It's an unconscious anxiety inside that causes people to have a phobia. All right? Now, if we could identify what the exact anxiety was, we could work on that. But we can't. And normal coping mechanisms haven't worked. But for some reason, this fear may help me cope better. Okay? Or the anxiety presents itself, I should say, as a phobia. Now, panic attack. If I'm in the middle of my panic attack, you better stay away from me, because if you get too close to me, what am I about to do to you? Whoop you again, beat you up. All through nursing school, I've beat you up at least once a month, okay? Because I have panic attacks. Use simple words when you're talking to me. Because can I understand complex messages? You gotta get simple. And I have to learn how to stop the anxiety. Well, to learn how to stop my anxiety, I've got to learn how the anxiety feels when it's starting to come on, don't I? So that's the first thing you got to do, is learn how it feels in the early stages. Teach that symptoms should peak within 10 minutes. Teach journaling to manage anxiety and help the patient gain insight into the peaks and valleys of anxiety and triggers and relaxation techniques. Now we have somebody that's hallucinating. Well, warn before you touch them. If you touch them without saying something to them first, could it scare them? Yeah, and when they get scared, they can get violent. You have to be careful. Don't say they, because that makes the hallucination seem real. That makes the hallucination seem real. You let the patient know that you do not share the perception. In other words, you don't ever act like you can hear it. You don't act like you can see it, because what are you doing then? making it worse. You're reinforcing the hallucination. You never reinforce a hallucination. Never, ever, ever. They're connected with times of anxiety. The more nervous and anxious somebody is, the more they hallucinate. And what we want to do is involve an activity. Here's the NCLEX thing. You get them out of the hallucination and into the real world. Get them out of the hallucination and into the real world. Elevate the head of the bed. They don't know why, but people have more hallucinations lying flat. More hallucinations lying flat. And turn off the TV. Why? Because that's just more stimuli. We're limiting stimuli. And offer reassurance because the client is frightened. And then the last thing we're going to talk about is ECT, electroconvulsive therapy. This can induce a grand mal seizure. Okay? It's for severe depression and manic episodes. It's a last resort. Okay? In pre-procedure, y'all, it's just like anything else. NPO, void atropine. Why are we giving the patient atropine? So they won't aspirate. Dry up secretions. So they won't aspirate. Dry up secretions. Signed permit is necessary, and they'll have a series of treatments, and that depends on the patient's response. In other words, how they react to the treatment. Very effective treatment and very humane with current medicines. Anectine relaxes the muscles. Relaxes the muscles. Okay? Because, y'all, if we are inducing a grand mal seizure, could we make their muscles get so tight that they break something? Yeah. Always look for injury post-procedure. If I didn't have a backache before I went for ECT, should I have one when I come back? No, that's a problem. So we're relaxing the muscles with an Anectine. Post-procedure, put me on my side so I won't aspirate. Stay with the patient. They're scared. They're confused. Temporary memory loss is expected. Reorient over and over and over again. And, always tell the family before they come to visit that the patient's going to be confused for a little while because they're expecting their family member to be better after this treatment, and now the family member's more confused than ever. Be sure and tell them that does get better with time. And involve in day's activities as soon as possible. Remember I said one of the best NCLEX strategies on psychiatric nursing is to get people involved and active in things that are going on in the unit. All right, enough on psychiatric nursing.